There. Good morning, Californians, and good evening, Nigerians and UK citizens joining us this day. Today, we'll be having a beautiful outing looking at gastrointestinal carcinomas. Let me just share this slide briefly. Are you seeing my slides?
Yes.
Good. So this program is brought to you courtesy of Community Health Awareness Program in partnership with Center for Family Health Initiatives. Every month we have a health topic that we discuss. Last month we discussed on diabetics, and this week we're looking on gastrointestinal cancers. Please understand that our presentation is just for informational purposes only. It does not replace your doctor's advice. If you have health issues, please consult your medical practitioner and provider for medical advice. Why are we here today? Gastrointestinal cancers are very, very common, and they are responsible for significant pain and loss across the world. Today, you will hear from world experts. Please listen, take notes, reflect, and document your questions and share your experiences. At the end of today's presentation, we'll take a number of questions and we'll review your comments. And please follow us on our YouTube channels and social media platforms if you can. We're here today to provide you with information on gastrointestinal cancers, share some basic facts, offer hope to those who are going through a challenge right now of any of the cancers that we'll be talking about today, and also give you access to support for in any way we're able to provide. Let me begin by showing you what the gastrointestinal system looks like. It begins from the mouth, through the esophagus, down to the stomach, through the small intestines, and all through the large intestine to the cecum and then the rectum. So today's cancers, we'll be looking at the cancer that affects the esophagus, the liver, the stomach, the pancreas, intestines, and the cecum. And what are cancers? These are malignant conditions that develop in the digestive tract and other abdominal organs. Cancers are caused by uncontrolled growth of abdominal cells, and they include esophageal cancers, gastric cancer, colorectal cancer, pancreatic cancer, and also liver cancer. Today, you will hear Dr. Obinna talk to you about colorectal cancers. Peace will talk to you about esophageal and gastric cancers. Dr. Nkechi Ikejiofo will talk to us about liver and pancreatic cancers. And Maruja Tose will talk to us today about nutritional management of cancers. And I will be running up with questions and answers. Here are our team members today. Dr. Angela Febu and Dr. Esther Okafor are on a conference and may not be joining us today officially, but if they are available, they'll take some questions. Also, Dr. Joyce Lazarus. Why are we focusing on gastrointestinal cancers this morning or this evening, based on where you are? You will hear about their frequencies with each of the presentations. However, it's important to note that GI cancers are common and more likely to develop in men than in women. The risk also increases with age. The older you are, the more likely you have cancer of the GI systems. A small percentage of GI cancers are inherited, and most times symptoms only occur when the cancers are advanced. Some actually have mortality rates of up to 90% in our generation. So join me this morning, so evening, to welcome Dr. Peace Ome, DNP, as she presents to us on esophageal cancers along with gastric cancers. Peace, you're welcome.
Thank you, Dr. Leribe. Good morning, everyone. Today, I will be talking about esophageal cancer and the stomach cancer. Once again, thank you for joining us. We do appreciate your time with us today. And I hope you enjoyed this moment with us. So we have World Cancer Day, usually on February the 4th of every year. And of course, this is a time that you want to know. You want to find those activities and measures to protect yourself from cancer, especially if you have family member or you know anyone who has gone through any type of cancer, February 4th is that day that we do raise awareness. So yeah, next slide. So before I continue, I just wanted to show you a quick picture of esophagus, the organs I will be talking about this morning. The esophagus, the long tube, and the stomach. Next slide. And the statistics for esophageal cancer is just alarming to know how many people that have been diagnosed with cancer in the US. About 22,370 new esophageal cancer cases diagnosed, and 17,690 in men and 4,650 in women. We are looking at about 16,130 deaths, and it's most common in white people from statistics. Adenocarcinoma is the most common type of the esophagus cancer among the white people, and squamous carcinoma is more common in African Americans. And this information is retrieved from American Cancer Society website. Approximately 0.5% of men and women will be diagnosed with esophageal cancer at some point during their lifetime, and this is really alarming. Next slide, please. What is esophageal cancer? Like was introduced to us, esophageal cancer starts when cells in the lining of esophagus outgrow. They grow in enormous number, and this is what causes esophageal cancer. Next slide. So I'm looking at two different types of cancer. There are other types of esophageal cancer, but for the interest of this presentation, I'm looking at squamous carcinoma, squamous cell carcinoma, and adenocarcinoma, the two major types of esophageal cancer. There are these other rare cancers in the esophagus, the lymphomas, sarcomas, and melanomas. Next slide. So for squamous cell carcinoma, this is derived from the type of cell that you see or you find in the mucous lining of the esophagus. Esophagus is made up of 3 different linings. So the squamous lining of the esophagus will form the squamous cell carcinoma. Then it occurs, it could be any part of the esophagus, but most commonly towards the upper part of the esophagus, towards the neck and middle part of the esophagus. Then the other one is the adenocarcinoma, the type that starts in the gland cells that make mucus and is often found in the lower part of the esophagus for the interest of this presentation. So prevention for any cancer, actually, there's no particular way to prevent cancer, but there are things that we can do to lower the risk of people developing cancer. So some of the risk factors, which of course, some of them you can modify, some of them you cannot, like the age. Of course, you cannot modify age. The chance of getting esophageal cancer increases with age, and as stated in our introduction. Sex. Unfortunately, men are more likely than women to get esophageal cancer. Tobacco and alcohol, diet, acid reflux disease, Barrett's esophagus. And Barrett's esophagus will mean this is a condition whereby someone has been dealing with acid reflux for a long time, and at some point it develops this condition. Next slide. Physical inactivity. Of course, this is, you can modify this. You can get up and go and get exercise, and just lower the risk of being obese. Then achalasia is another type of condition in the lower part of the esophagus, resulting from long-term damage to the nerve, whereby the esophagus, instead of contracting and dilating to push down food, the foods tend to stay longer there. At some point, it causes a problem. What are some of the signs and symptoms? Trouble swallowing, weight loss, hoarseness, cracked voice, chronic cough, chest pain. So some of these symptoms may not just identify or tell us that this person has esophageal cancer. Some of these things. So what the point I'm trying to make is that because you have trouble swallowing doesn't mean that you have esophageal cancer. So there are some other things. Then bone pain. If that cancer has spread to the bone, bleeding into the esophagus, which usually the blood will go through the GI tract and goes down to the colon. Of course, by then the stool will look black. Next slide. Then there are some other symptoms, symptoms that may develop because the cancer has actually advanced. Then some of the imaging that we do in order to diagnose esophageal cancer, we're looking at, and usually these imaging testing or exams are done to look at a suspicious area. With X-ray, you may see something really triggering, suspicious. Then you may request further imaging testing to learn how far the cancer might have spread, to also determine remission if this cancer has actually slowed down, and also to look for possible reoccurrence, because sometimes after treating cancer, it reoccurs at some point. So there's what we call barium swallow. This is a test. This is a test using a thick chalky liquid that goes through the esophagus, and there it will align that, or it will identify a suspicious area. Then CT scan, MRI, PET scan, endoscopy, of course, lab work. You can do cytology with the tissue samples that is gotten from that part of the esophagus that you're suspicious of, that is suspicious of cancer. Then blood tests like liver enzymes, because esophagus and liver, they're very close to each other. So complications or the esophageal cancer can advance, affecting the liver, unfortunately. So when we talk about this, we also want to give you hope, because there's survival rate, and which is usually based on the age of the patient, the sex of the patient. As we say that this is more common in men than in women, and of course your general well-being. Someone who is sick may have poor prognosis than someone who is healthy, not even dealing with any type of condition. So survival rate depends on different factors. Then here, and this is all numbers for stage. If that cancer is still localized, if it's just there, that small portion of the esophagus has the cancer, the survival rate is higher than when it has affected it has left that particular spot and affected surrounding organ. And of course, if it's distant, whereby it has actually affected some lymph nodes and other distant organs from the esophagus, the survival rate is lower. And remember, this depends on some other factors, and these are all numbers. So these numbers, when you look at them, it doesn't actually tell us exactly, but We just you just have to know that there are factors that could make your outcome better than the other person. For some earlier stage cancer, surgery, they can just use surgery and just remove that portion of the esophagus tissue that has cancer. In some cases, it may be combined with chemotherapy or radiation, or there are specialty medications that are targeted, that these medications, they just target the cancer and treat them. Of course, these are given by the specialist oncologist. Then immunotherapy, supportive management, immunotherapy, because cancer, some cancers are, but for this cancer, it could be because of immune response, because of genetics. So they give medication in order to change the immune system and be able to cure the cancer. Next slide. Then, so these are some of the professionals and the experts on one particular cancer patient: the thoracic surgeon, the surgical oncologist, radiation oncologist, medical oncologist, plus the nurse practitioners, the physician assistants on the case, of course, the gastroenterologist, the doctor who specializes in the GI cancers or the GI condition, which is our topic today. Next slide. So just to show a picture of an example of tumor of the stomach. So talking about stomach cancer, just for you to see where you can find the tumors in the stomach. Most of the time, the stomach cancer, you find them at the upper part of the stomach, of the body of the stomach. Just for a pictorial overview. Next slide. So as far as introduction, in the early 20th century, stomach cancer was really high, affecting a lot of people and leading as a leading cause of death in the United States. But today, because of some reasons, there are some reasons that it is assumed that this condition has lowered in the US. The next slide. There is, of course, every home in the US, I don't know any home that doesn't have a refrigerator. So most foods are being preserved in the refrigerator, as opposed to previously, most food items were preserved, smoked, or preserved with salt, or with some agents or chemicals in the past. But because of refrigeration, it is assumed that this has actually lowered the incidence of stomach cancer. There is a bacteria that usually lives that affects the stomach. This is one major cause of stomach cancer. So because of the decline, because there is treatment, there's improved lifestyle, this particular organism, bacteria, has been, is cured, it's being controlled, thereby lowering the incidence or high risk of developing stomach cancer. So about 26,890 new cases of stomach cancer, and we're talking about the US, 16,160 in men and 10,730 in women. About very high number causing death from this type of cancer, unfortunately. Stomach cancer accounts for about 1.5% of all new cancers diagnosed in the US each year. Signs and symptoms: someone may start feeling bloated after food, feeling full, like just eating small amounts of food, loss of appetite, indigestion, nausea, vomiting, weight loss. So the goal is to make sure that when you have any abnormal symptoms, you do not ignore any type of abnormal feeling, especially these symptoms. And does not mean that once you start feeling bloated, that you have stomach cancer, but you need to check these things out. Next slide. Swollen, firm, non-tender lymph nodes. When you present yourself to your doctor, of course, we do physical assessment to identify anything that is abnormal. A mass in the abdomen that can be felt, or that feeling of fullness could be because there's something growing in the stomach. Abdominal pain, shortness of breath, low red blood cells, like if there is bleeding in the stomach, that could lead to anemia. Stools that look black, as in esophageal cancer, bone pain. And some of these ones are the ones that you may see when the disease has advanced. So risk factors, just like we talked about esophageal cancer, risk factors, again, are some of these risk: sex, which of course you cannot modify, age, ethnicity. These are some of the non-modifiable risk, but the modifiable risk, you can stop smoking. H. pylori infection can be treated. Stomach polyps can be removed. If you had stomach surgery in the past, of course, previous stomach surgery, limiting the space of the stomach, limiting the function of the stomach, especially the production of acid. If that happens, acid makes a safe environment for the stomach. But when that stomach space is reduced, of course, it limits that function of the stomach. Stomach cancer are more likely after stomach surgery. Next slide. So how do we prevent this? Most cancers will be prevented by these measures: good diet, nutrition, normal body weight, physical activity. We cannot overemphasize on these measures, on these activities as factors to lower risk of developing any type of cancer. But for stomach cancer, quit alcohol. If you started drinking already, quit alcohol. If you haven't stopped drinking, more than 3 cups of alcohol for men is too much in a day. That's too much. So work on that. Avoid smoking. If you have started, please don't start. Don't start if you have not started smoking. Treating the infection that is one of the main causes of stomach cancer. There's studies have also shown that use of aspirin or maybe ibuprofen, naproxen, that these will protect your stomach from developing stomach cancer. But we do not just place patients on these medications to protect them from developing stomach cancer. Then genetic testing. If any family member, extended, other generations, first, second generation, please go for genetic testing. Talk to your doctor to check if there is a likelihood of you developing stomach cancer. Next slide. And most of the treatment, just like I talked about in esophageal cancer, same treatment: radiation, chemotherapy, surgery to remove the tumor. You may also require chemo or radiation and all that. And of course, the good news is to catch these things at early stage, as soon as possible. If you have any abnormal symptoms, don't ignore any type of symptom that is not usual for you. So talk to your doctor. And of course, next slide, when you have, when anyone is diagnosed with cancer, or you know anyone, this person might be so worried. And of course, knowing what to expect every step of the way, knowing the diagnosis, what stage of the cancer, how far has it gone? Being aware of the treatment and the side effects, the programs and services that are available to help you cope with the cancer, the expectations throughout the treatment and after treatment. Just being aware of these things makes a lot of difference. It empowers you. It empowers you to know that you can fight this, you can handle it. And next slide. And of course, just like I said, where is this cancer? What stage? Has it gone beyond where it started? Will I need other tests? Do I need to see any other doctor? Those professionals, experts on the team who can help me when costs or coverage pose a problem or concern to me. And just being aware, which is the reason why we are doing this today, just empowering our community, giving our community the information that they know. Like we said in the beginning, it doesn't replace your medical visit. It's just to create awareness. And I hope you enjoyed my session. Thank you. And right now, I will be welcoming and introducing our next speaker, Dr. Nkechi Ikejiofo. Please take over the screen. Thank you.
Hello.
Hello, hi.
Hi, how are you?
Yes, good. So take over the screen. Thank you.
Okay, thank you. Thank you, Dr. May. Thank you for introducing me. Thank you, everyone, for joining us today with this awful topic. I wish we had a better topic to give. However, it's still something that we all have to know about because certain things we can't predict. No one wishes it, but when it comes, it has come. As previously introduced, my name is Dr. Nkechi Ikejiofo, hospitalist. Okay, now I'm going to talk about liver and pancreatic cancer. So thank you, Dr. May. You've already shown us the anatomy of the GI. Can we just, okay, here, I'll start with the pancreatic cancer. When we finish this, then I'll go to the next slide, which will be the liver cancer. So pancreatic cancer, what is it? The pancreas, we have anatomy. In your stomach, you're looking at the screen, you see that long thing, yellow long thing that looks like a long tongue. That's called the pancreas. It's a gland in your body. So any cancer originating from that is called pancreatic cancer. And this pancreatic cancer is a very aggressive cancer that nobody ever wishes to have. Very aggressive in the sense that before you find out that you have pancreatic cancer, it must have gone to like stage 3 to 4. So the month for pancreatic cancer awareness is November, and the ribbon is purple. So in the month of November, please do pay attention to everything you want to know about this. Okay, now, next slide. Is the statistics the next slide? Okay. This cancer is, for now, the number 3 leading cause of cancer-related death in the United States. And it's predicted that by 2030, this is going to take over gradually to be the second leading cause. That tells you how serious and how alarming this pancreatic cancer is. Every day, there are new cases, about 66,440, combining men and women. The death is alarming, about 51,750 people. So it's a very aggressive cancer. Next slide. The survival rate, I need to say the survival rate of this cancer is before about 4 to 5, but there is hope. They're telling us now that it has increased to like 13%, the 5-year survival. So there are 2 types of pancreatic cancer. One, the first one we call the exocrine. The exocrine are the glands that they are responsible for everything, metabolism of your fat, carbohydrates in your body. And this type of cancer makes about 95% of pancreatic cancer. Then we have the neuroendocrine, which is the ones that we see in the bile duct. Next slide. Okay. Now, these cancers, what can we do? Now we've known about pancreatic cancer. There's a pancreas in our body. The cancer is very deadly, very fatal, doesn't give you time, very aggressive. Is there anything we can do to avoid having these cancers? Yes, we do have some modifiable risk, and we have the non-modifiable risk. About the modifiable risk, as self-explained from the previous slides, we see obesity. If there's anything we can do to reduce our weight, stay within our BMI, please try and do it. Healthy lifestyle. Then diabetes, if you can, reduce your chances of getting diabetes, being diagnosed with diabetes. Though some diabetes you don't have control over it, but some, if you can reduce your risk factors for diabetes, please do so. That will also aim you reduction in the chances of getting cancer. Then chronic pancreatitis, inflammation of the pancreas. These ones you see mostly on the alcoholics. If you can avoid drinking those alcohols, stop killing your pancreas. That will also help. Alcoholism, this is one factor that we have thorough control of. Yeah, you have thorough control that you can finally eliminate having this risk factor at all. Take it off your plate, scratch it out. Then tobacco use, something that you also have total control. You can also do. Then non-modifiable risk factors. Unfortunately, age. We all have to age, regardless of all age-defying lotions, everything we have to put. We fight it, but unfortunately, it's meant to happen. So we're gonna age, that's not modifiable. Then we have genetic, we have gender. We did not select our gender when we were born. And then we have it, even if we do some surgeries to turn it around, but the glands in your body still remain your original gender, so that you cannot change. Race, the black more for this type of cancer. Then we have genetic, those ones that are genetically inborn, the cancer cells. Then signs and symptoms, how do you know you have pancreatic cancer? Because most people come in with, oh, my belly hurts, abdominal pain. But the thing is that before this cancer gives you any symptoms, it has gone beyond stage 2. Believe it or not, it's very aggressive. Most people come in 3 and 4 stages. So for now, you see yellowness of the eyes, your urine is dark. When you start losing weight unintentionally, back pain, I'm not talking about lower back pain from pulling or from age-related arthritis. I'm talking about localized pain on your back, on certain area of your back, where we have the pancreas. Then your urine gets dark, your skin starts turning yellow, your blood, you start throwing blood clots from nowhere without history of long travel. Say you have a blood clot on your leg, then you need to run to your physician. When you go, they're gonna rule out different diagnoses, try to narrow it down. Next slide, please. Diagnostic studies. How do we diagnose people with pancreatic cancer? Since this pancreas is way inside our body, yes, we have CT scans. When you go to CT, the computer is going to pick up if there's any issue of malignancy. It's going to tell you a question about this. Then we have the MRI that will look at your blood vessels. We have PET scan to stage it. Then in most cases, we send patients for EUS, we call it endoscopic ultrasound. Not every hospital does this procedure. Like where I am, we usually send out our patients to tertiary, like Keck or Long Beach or Cedars, to get EUS, where they put in a scope, go down to your pancreas, look at it, and obtain a biopsy. Then blood tests to look for tumor markers, abnormal liver enzymes. Then we have staging like laryngoscopy, where they put a scope. So diagnosing a patient with this cancer takes multiple specialties. Sometimes you get from GI, you're unable to get it, then you go to IR, unable to get it, then you go to surgeons, trying to diagnose patients with this pancreatic cancer. Next slide, please. Staging, we have stages 0 to 4. So, the higher, the worse, the lower, the better. Then treatment of this cancer. On this slide, I think they don't have the surgical one, but I'm going to talk about the surgical. Okay, let me start from, even if you're going to have chemotherapy, radiation, most of the times, if you caught early, like stage 1 to 2, they go for what we call Whipple procedure. In other words, medical terminology, we go like pancreatic duodenostomy surgery. And that type of surgery is a very high-risk surgery. They will consider your age, your lifespan, how many years you have lived. You don't send an 87 or 90-year-old patient with pancreatic cancer for Whipple procedure. They look at if it's like 50, 60, depending on your age and your lifestyle and comorbidities. You go for this surgery. In that surgery, they're going to remove a couple of things. Usually like the head of the pancreas, some portion of your duodenum, some bile duct, some lymph node. It's a very complex surgery, but usually stages like 1 to 2. You don't send anybody with stage 3 or 4 for Whipple procedure. Then you can send patients for like chemotherapy or choice of chemo, depends on the oncologist, radiation therapy, immunotherapy, where you use immunotherapy to kill the cells of the cancer. Then some people are with like stage 4, you refer them to palliative care. Palliative, some of them do give chemotherapy, or call it palliative chemo. It's aimed at reducing the symptoms you're having. It's not curative chemotherapy. It's just to reduce and give you some more quality of life before the end. Now, with this type of cancer that I have just discussed, is closely related to this liver cancer. Okay, so now let's go on to liver cancer. Liver cancer, of course, we all know is the largest organ inside the body. It has the capability of regenerating. And now when cancer happens around any part of it, it turns to liver cancer. And now let's go to the next slide. October is the month, Liver Cancer Awareness Month. So please pay attention to the month of October, and the ribbon color is green. So liver cancer, another leading cause of cancer in the United States, is ranging around the 3rd, but if caught early, there are good news to it. And this liver cancer, we have 2 types. One is the, next slide, please. I'll come to this, that this is the part of liver cancer. One starts primarily at the liver, and then we have the one that started from other organs, then comes to the liver. So now statistics. According to American Cancer Society, it is estimated by a few years to come, this cancer will also take up a leading role if care is not taken. About 41,630 new cases will be diagnosed. And then there's also going to be a death toll on those ones. So this is what they're giving us. The median survival rate, again, 5 years is much better in liver cancer than pancreatic cancer, because in the sense that this is about 17%. The pancreatic cancer I just discussed is about only 13%. So even combining both of them, you could tell that these two are not joke. Both of them are less than 20%. Next slide. Types. Like I said, we have primary liver cancer, and this in primary liver cancer, we have like the hepatocellular carcinomas. This accounts about like 80% of all cancers. Then we have the intrahepatic cancer, which is in your duct, about 20%. And then we have the secondary type, which is cancer that originated from neighborhood of stomach, all of them, then they come to the liver. So that's secondary type. Risk factors, just like we discussed before, but this one we still have some control, like chronic hepatitis. If you can avoid having all those tattoos, PS, and anything that could subject you to hepatitis C, please do, please stop that one, cross it out. If you have chances of getting your hepatitis vaccines, please do it. There are some risk factors to this, like chronic hepatitis, certain liver diseases like liver cirrhosis, scarring of the liver, non-fatty alcohol, non-fatty liver disease. So these are some risk factors that can push someone onto liver cancer. Signs and symptoms. it mimics like pancreatic cancer, unintentional weight loss. I know we all over our BMI, we all want to lose weight, but when it's not happening without you doing any effort, please start making a mental note that this is not normal. Why am I losing weight? Unintentional weight loss, loss of appetite, upper abdominal pain, nausea, vomiting, yellowness of your eyes and your skin. You could tell. I know we are like, some people are light skin, but you can still tell the difference between light skin and somebody who is yellow. And abnormal bloating, ascites, you coffee. Then diagnostic studies. How do we diagnose cancer of the liver? Blood test, look for abnormal liver enzymes. Some of them come in massive alarming levels of the liver enzymes. Then physical. Actually, when you're looking at their eyes, their abdomen, how distended, then we'll do like ultrasound, CT scan, MRIs, angiogram to look at the blood vessels. These are part of them. We send for like scopes, like I had explained previously on pancreatic cancer, some EUS, some ERCPs, endoscopic retrograde. So, next slide. Stages. When you get diagnosed, then the next thing will be staging your liver cancer. Like I always explain, the earlier the better. If caught early, you have chances of getting onto like liver transplant list. So you have stage 1, it's self-explanatory. The higher the number, the worse. Stage 1, confined, then treatment. I know the slide was so fast. It's okay, but we have, can you go back to the slide of the stages, please? Yeah, so we have stage 1 through stage 4. Stage 4 is not good. Let's try, if you have those symptoms, the goal is to catch them early enough, stage 1, 2. Next slide, please. Treatment. We have surgical treatment. We have that people did like liver transplant. You remove the part of the liver that has the tumor, like in stage 1 where it's confined. Then you have liver transplant. You have radiation therapy where they use the radioactive rays to kill the cancer cell. You have radiofrequency ablation. It's like using it for, you know, when the welders are welding something, yeah, they use that to burn off those cells in there directly. Then you have the cryosurgery where they use like liquid nitrogen to freeze those cancer cells. Then you have local chemotherapy where they put the chemotherapy directly on the cancer cells. And then you have the immunotherapy where they use your immune system trying to fight the cancers. And then you have percutaneous external therapy where they put those high concentrated alcohol directly on the liver cells. So there's still hope because liver cancer, they can still have quality of life if managed and treated on time. Next slide, prevention. How can we do? What can we do? How do you prevent liver cancer? So we've already talked about dieting and all those ones. So drinking alcohol in moderation, maintaining your healthy lifestyle, get vaccinated, take measures to prevent hepatitis C, limit tattoos, piercing, anything, needle sharing, then seek treatment for hepatitis B or C infection if it happens. So these are the references we have gotten from American Cancer Society. And now, later we're gonna take questions. So I'll go ahead and bring on the next presenter, Dr. Obinna Oloribe, to take us down to colorectal cancers. Thank you so much for your time.
Thank you, Dr. Nkechi, for that presentation and for leading us through pancreatic and liver cancer. It's also important that we know that these are not just stories. People have had these diseases and many have died from them. I know that Steve Jobs of Apple died from pancreatic cancer, and also I have 2 family members that died from liver cell carcinoma. So these cancers are not far away. They're around us and within us. And the more we know about them, the faster we can take precautions, change our habits, and make early diagnosis for better health care. I'll be talking to us this afternoon and to this evening on colorectal cancers. We've heard about esophageal cancers, gastric cancer, pancreatic and liver cancer. Now, what happens next? It's important we know that also that the month of March is colorectal month. And so almost every month of the year, there's a cancer that is being remembered because of the number of people that have been victims of those cancers and may have died from them. Where do we have the colorectal region? If you look at the intestine, for instance, the small intestine comes here. And then you have the ascending colon, the transverse colon, the descending colon, the rectum, the cecum and the rectum, and then it goes out to the anal region. So every cancer that involves this segment of the intestine or the GI tract is called colorectal cancer. They are the third most frequent diagnosed cancers and second most common cause of cancer-related death worldwide, not only in US, but around the whole world. Actually, it is the most common and most treatable GI cancer in the United States. And etiology remains unknown, however, 5 to 10% may be inherited through genetic risk factors, but remaining cases occur sporadically, and most cases are related to unhealthy behavior. That's why it is both treatable and also to a large extent preventable. There are three main types of colorectal cancer. The rectal cancers, about 50%, the colon cancers, about 49%, and then both sides combined, about 1.25%. In the colon cancer, you have the sigmoid cancers, ascending cancer, transverse cancers, and other forms of cancers. However, studies have shown that although here you have the rectal cancer more common, that current diagnosis show that we are having more colon cancers than rectal cancers at the moment. And it occurs mostly in men, more in men than in female, 1.3 to 1 ratio. And if you are above 50, 58 to 60, then you are more prone to having cancer of the colon and rectal region. That's why prevention and early assessment is critical. And we are now seeing more colon cancer than rectal cancer, as I said earlier on. We've had so many risk factors this morning and this evening, and they are all about the same: environmental factors, lifestyle, diet, age, habits, cigarette smoking, alcohol, and unhealthy diet. It's important for us to know that the single commonest cause of illness globally today is tobacco. Tobacco is the single commonest cause of illness globally. It is responsible for all manner of cancers, all manner of lower lung diseases, all manner of skin problems, cardiac problems. So if we can stop tobacco completely, and number 3 commonest cause of diseases worldwide is alcohol. Tobacco, alcohol. Number 2 is diet and inactivities. So if we can control these modifiable factors, we will, to a large extent, reduce the prevalence and incidence of non-communicable diseases globally. So it's the same risk factors. We can't change our age, we can't change our sex or gender, we can't change our genetics. Like Nkechi said, even if you go and do a sex transfer, becoming a man to a woman, your gene remains the same, your sex chromosome remains the same, so you are still prone to the same diseases. But we can change what we eat, we can change what we drink, we can stop what we are smoking, and by so doing, reduce the pain that comes from these cancers. As I said earlier on, it could be linked to your gene. For instance, there's about 3-fold increased risk of cancers in first-generation relatives of people who have colorectal cancers. Also, the food you eat, if they are high in fat, high in animal protein, low cellulose diets, they all can lead to increased CRCs. You also have some diseases of the colorectal region, like polyps, adenomas, ulcerative colitis. They can be predisposing factors to colorectal cancer. And others could be things like exposure to carcinogens or even overweight and pelvic radiation with X-rays. If we can avoid what's avoidable, we can reduce the frequency of this cancer. That's my message this afternoon. What are the pathologies? It could be, if you look at it grossly, you may see an ulceration of the colon. or the rectum or the cecum, or even an infiltration into the nearby organs. And the commonest form of colorectal cancer is adenocarcinoma, which account for over 90% of all cases of colorectal cancers. The other 10% are local invasions, lymphatic metastases, hematogenous metastases, and also implantation to other organs. Signs and symptoms, majority of them are asymptomatic in the early stages. There are no symptoms at all. You just feel normal, you have a normal life, but inside you have a problem. That's why screening is important. And if you are above 40 years of age, like me, if you're above 50, then you should be doing screening at least once every year to ensure that you are free of colorectal cancers. If you have blood in your stool, what they call hematochezia, that's also another significant evidence of something going wrong in your gastrointestinal system. It could be the colorectal region, it could be the stomach region, or even the esophageal region. But once you have blood in your stool, it's a major indication for more investigation. If you have intestinal obstruction, in advanced cases, you can't go to toilet, you struggle to go to toilet, you have constipation, you have mass in your stomach. These are also evidence that something is wrong in your gastrointestinal system, and it could be a colorectal cancer. And if you have systemic symptoms like loss of weight, like you've had earlier on, cachexia, anemia, emancipation, then please check your health. Something may be going wrong in your whole body. Diagnosis, like you've had earlier on, is critical, and earlier diagnosis leads to better prognosis. Most of them have no obvious symptoms and signs in the early stages, so screening is the key word here. However, once you have an advanced case, then you may have symptoms of, you may have a modified stool habit, you may have constipation, you may have abdominal mass, you may have all manner of symptoms that are not normal for you, and these are these are evidence that something is going on in your GI system. So what do you do when you go to your healthcare provider? They want to do a rectal examination. That could just be all they will do. They find the blood in the glove, or a mass in the rectum, or in the that is very, very, very cardinal. Then they can do what they call fecal occult blood test. This is also what you do maybe in your annual screening. You find out whether is there blood in my stool, and then you look for tumor markers, do endoscopy, just go through your anus to look into the rectum and the colon, using a scope to find out. You can do X-rays, ultrasound, CT, or MRI, like you already had. Any of this can help you make a definitive diagnosis. You can also do a biopsy. But please, when something does not look normal, it's important to find out what is happening. Your high sense, your index of suspicion is critical at this point in time. And please do not play with your intuition. It could be a pointer to longer living. So when somebody around you, not you right now, when somebody around you have colorectal cancers, what are important things you must know? Early diagnosis can significantly improve prognosis, because patients who are identified very early have up to 90% cure rate, if early. But if not early, then it's not good. So please ensure that if you have any change in bowel habits, if you have any abdominal discomfort, if you have any blood in your stool, if you have any feeling of unwell that you can't really identify what is causing the problem, please check yourself. Depending on the stage of the tumor, the patient may actually have surgery, chemotherapy, radiotherapy, or even molecular targeted therapies. These are all forms of therapy that are available here, and a few of them are available in our own country, Nigeria. But please, early diagnosis is key. So even if you don't have the money, screening is very, very cheap, and in some centers it's free. And if you have insurance, it's completely free. How do you prevent colorectal cancer, therefore? First is diet, lifestyle changes, active treatment, and then regular screening. I've said that earlier. I kind of overemphasize it. Low-fat diet, fresh vegetables, fruits, good fiber foods, appropriate minerals, and trace elements are critical in your diet. That's also why I advise people cook your food. When you cook your food, you know what you're eating. Here in US, many people hardly cook they eat from restaurant to restaurant, which is very good, but it's not a sign of being wealthy. You have to learn to cook your food so you know what to eat. I make the habit to at least every day take some fruits, either as raw fruits or as I blend them with my drinks, and those things are very healthy for people like you and I who are above 50 at this point in time. But if you're younger, then start the habit early. Watch what you eat. Going to McDonald's, Burger Kings, and all those places, it's not an evidence of being wealthy or healthy living. You're eating junks. Learn to watch what you eat. And I'm sure that Mocha will talk to you more about diet in this presentation. Then lifestyle changes, quit smoking. If you have started smoking, if you're not started, please don't start. Limit your alcohol intake. Ensure proper exercises and weight control. Then if you have any abdominal condition like polyps, adenomas, go for treatment. And regular screening is critical. This is my message for this day. Empty your bowel at least once every day. Even when you don't feel like it, go out there, sit down there, read your book, play your games on your phone until something comes out. If you do not empty your bowel at least once every day, you allow your body to reabsorb what ought to be excreted in terms of water and chemicals. And the longer they are in your long intestine, the large intestine, which is your cecum or rectum, the more likely they will cause abrasions, injuries, and maybe cancer of the colorectal region. So my message for us is today, keep your convenience clean and go in there and sit down there and ensure that something goes out every day from you. If you can do it twice a day, that is a very beautiful habit. What is the prognosis? The stage of disease at diagnosis is the most important factor in prognosis. 5-year survival rate for patients with localized CRCs who had complete surgical resection is above 90%. But 5 years for those who have advanced CRC is only about 10%. You can see the difference, 90% and 10%, depending on at what time it was diagnosed. So the earlier it's diagnosed, the healthier you will be. In conclusion, therefore, incidence and mortality is high and increasing year by year based on our changing dietary habits. Early diagnosis can significantly improve the diagnosis, the prognosis. Patients often have no typical clinical symptoms or signs except they have advanced cases. So if you can identify it early through screening, please ensure you go for screening at least once every year. If people you know have died from colorectal cancer like Cadwick, Bosman, and Natalia, you and I will not be a victim of it as we take the necessary steps. Thank you for listening. Please join me and welcome our next presenter and our last presenter for today, Mocha, as she takes us through nutritional management of cancers. Mocha, please.
Thank you for that introduction. Okay, guys, I was like, I'm Mocha, how you doing? So we are doing, look, I will be going in on nutrition, what you should be eating, what you can eat to prevent or reduce your risk greatly of getting the GI cancers. So let's start with prevention. Can you prevent GI cancers? That's usually the biggest question that I get. And according to the GI Society, nutrition and the lifestyle factors play a major role in the prevention and management of cancer, including stomach cancers. So you can greatly reduce your risk. Just know that when people say, you know, oh, I'm going to get it regardless, not true, not true. I was like, you can do what you need to do. And a lot of it has to do with the food that you're eating. So what are the foods and what else can you do to prevent your GI cancers? You can reduce your salt and sugar. That's a huge one. Eat garlic. And I know a lot of people are thinking the garlic cloves, but you can actually eat those. It's going to be a little bit strong in your throat, but I was just like, those are really, they're a lot of good that a lot of people don't know about. You could reduce your alcohol. Don't start if you don't drink. I was like, don't start. Coffee and green teas are actually okay. Eat vegetables and fruits, which I'm sure all of us have said this, you've heard it. Citrus, if you can handle doing citrus, like your citrus juices, squeeze them yourself. If you happen to have oranges, squeeze those yourself. You don't want anything pre-made for you, or if you happen to know the people that are making your own juice and you can speak with them and you can watch them squeeze it so you know they're not putting anything strange in your juice, that's a good deal too. Red meat, for a lot of people, especially men, when they say don't eat red meat, it's just don't eat it like every single, you have the people that they like something and so they eat a lot of it, like hamburgers or whatever it might be, the steaks. They might, eat that two times a day, maybe have steak and eggs in the morning, and then you have a hamburger at night. So we're saying reduce the red meat. And you do need to know what type of meat you're eating. So it must not be processed. The vitamins and mineral supplementation, I say go for the actual foods. However, do know that the supplementations, that's something that you need to speak with, because if you are going through treatment, if you happen to be going through treatment, chances are you're not going to be really hungry. And that's when you may need to get some supplementation in there. And that is something that you are going to want to go over with your dietitian that is a specialist with oncology, like the oncology nutrition. That's something that you want to do there. So what do you do, or what do you eat if you happen to have esophageal and stomach cancers? Folate. I need you guys to know folate. It's naturally present in a wide variety of foods, including your vegetables, your dark leafy greens, your kales, your spinach. Those are very good for you. Fruits, natural fruit juices. Like I said, have somebody squeeze them or you squeeze them yourself. Nuts, beans, peas, seafood, eggs, dairy products like your cheeses and your yogurts, meat, poultry, and grains. So there would be a next table coming up, but do hone in on the spinach. I was like, your liver, asparagus, and Brussels sprouts are among the foods with the highest folate levels. Next slide. So this, if you want to take a screenshot, this is like a general, these, the arrows that are next to your the squamous cell carcinomas, I was like your folate here, I was like, there's an arrow that goes down, so that is going to reduce your risk. The ones with the arrow up, I was like, your glycemic load or your glycemic index, I will explain that in just one moment. I was like, and then if you look at all of those, and then if you come down here to where it says decreased risks, you have your HEI diet, your Mediterranean diet, and your DGIA diet. Please keep in mind that these, you can go to the next screen. Keep in mind that these are generals. It's like a lot of people, this is not honed in specifically for one person. A lot of these diets have to do with, just generalities. You will need to speak with your dietitian, your nutritionist that is into the oncology, so they can hone in on what is specifically for you. Next screen. So your glycemic index that I was talking about before, the glycemic index is a rating system that ranks carbohydrates on a scale of 1 to 100 based on how they raise your blood sugar. We were talking about diabetes last month, so that has a lot to do with this. Your processed foods, such as your candy, your breads, cake, and cookies, all have a high glycemic index, okay? So stay away from sugar. I can tell you regular sugar, very, very high glycemic index, as opposed to, let's say, like a coconut brown sugar. For the same 2 tablespoons of that, it's like an index of 4, whereas your regular sugar is going to be high, almost like in your 80s. So just know that sugar has a lot to do with that. Your HEI diet, it refers to your healthy eating index diet. Your DGIA, now keep in mind, these are just explaining what was on the last table. The DGIA diet is not a specific diet plan, but rather it's a term that can refer to various dietary guidelines and recommendations. So with that being said, a lot of people, they want to try a DASH diet or a DASH eating plan. That's usually fat-free or low-fat dairy foods. Fish, poultry, beans, nuts, and vegetable oils. Okay, so the vegetable oils, we want to stay away from most vegetable, oils. The oils that are okay, which there's only 2, so it's not that difficult. The oils that are okay would be your olive oils and your coconut oils. All of the other oils, if you happen to see it, stay away from it. It is not good for your body. So you're going to want to limit the foods that are high in saturated fats, such as your fatty meats, your full fat dairy products, and the tropical oils. So your Mediterranean diet, that's another very popular one. The Mediterranean diet is a lifestyle. And I was just like, it's basically you're eating the minimally processed plant-based foods. That's what it is for the most part. It includes a variety of fruits, vegetables, nuts, beans, all of those things that we said were good for you. Whole grains and healthy fats, kind of like this one says olive oil. Keep in mind, avocados are amazing. They have good fats. And they're soft, which is helpful. The diet also includes moderate amounts of fish, dairy, eggs, and meats, as well as small amounts of red wine. So red wine, let's just take that out of there. That's how come you can't go specifically for one particular diet, because no, we're trying to eliminate the alcohol with all of this. Next slide. So your pancreatic cancer foods, since we went over specific cancers, the pancreatic foods, yes, look, I just put a yes here. Let's go with the yes foods. High protein foods with every meal. Protein, you're going to want to hone in on that. Men, I was like, when we do like animal proteins, be very careful of the red meat, as we stated before. Lean proteins are easy to digest, and they should be included with each meal and snack. Your baked, grilled, or boiled lean meats, such as your chicken, your turkey and fish, those are protein foods as well. Go with eggs, your nut butters. If it's difficult for you to digest nuts and anything like that, you can do nut butters, but I would say be very, very careful with your ingredients on the nut butters. It should be just, if it's peanut butter, it should be just peanuts. That's the only ingredient in it. They make their own oil, so it doesn't need to have any extra stuff in it. Same with almond and cashew butters. They make their own oil. You don't need any extra ingredients. Your low-fat dairy, such as your yogurts and cheese, your yogurts, you don't want it to have any extra fruits or anything else in it. Your Greek yogurt, you can make it taste like basically anything that you would like, basically. You can make it either sweet, or you can put salt and pepper in it, and it tastes more like a dip or something like that. I was like, and it's good. It's a good sour cream substitute. So keep that in mind. You also have beans, soy products. If you happen to do the vegan diet, tofu is really big for you guys. Protein bars, please watch out for any sugar contents in those protein bars. A lot of people don't like to eat because they say it tastes bland or it gets stuck in your throat. I was just like, do drink a lot of water with those. Most importantly, over here to the right, it says limit your consumption of insoluble fiber. Your insoluble fiber is that stuff that isn't absorbed by water easily. So therefore, it kind of pushes everything through your colon. I was like, it's keeping everything moving. So this is very, very important. However, I was just like, because it's difficult, especially if you're under chemotherapy or something like that, I was like, you're going to want more soluble fiber. So you're going to want to eat stuff like fiber oats. I was just like, and high protein or high pectin foods. And that's, I call it mushier food that turns mushier, kind of like bananas and applesauce and peaches, raspberries, blackberries, and apricots. Your peas, if you think about it, when you chew them, they turn kind of mushy. I was like, so then your green beans, your sweet potatoes, tomatoes, and all of those, they offer a high level of pectin. So keep those in mind. Choose colorful foods. Stay well hydrated. Water, I think of it kind of like if you have a car or you know anything about the cars. I was like, you have to keep the oil to keep everything moving. If you don't have any oil, then everything starts to go really, really stiff. You want to keep everything moving through your body as much as possible. So do drink water, a lot of water. I was like, stay well hydrated. I would say no less than, at the very, very minimum, I would say like a good 96 ounces of water a day. So that's going to keep everything moving. Avoid sugars and carbohydrates and fats. Those fats are saturated fats. Keep that in mind. Next slide, please. So your liver. I was like, so these are the yes foods, which you've heard many of us say, the fruits, the vegetables, your apples, leafy greens, all of those. But let's get to these foods to avoid. Okay, that's very important. The alpha toxins, I was like, they have a potential association with an increased risk of liver cancer. So what foods are those? Like your corns, your rice. Your rice is a multitude of things because you have to soak that rice. I was like, you have to clean your rice before you eat it. Otherwise, there's a lot of stuff that's on it that you're not aware of. Your peanuts, I was like, that's why I say peanut like oil, or not peanut oil, but your peanut butter instead of peanuts. Keep that in mind. You have sesame seeds, sunflower seeds, wheat, and some dried foods and spices. So glad you asked. What are aflatoxins? Aflatoxins are the result of fungal infection or crop contamination before and after harvest. So that's why you have your corns, your peanuts. They all come, if you think about it, they all come from the ground, and it depends on how long they're stored, where they're stored, and all of that. So they can also transmit to livestock through feed, resulting in the contamination of meat and other animal products such as your eggs and dairy. So just keep that in mind, okay? Your red meats, of course, we said the red meats. Processed meats are a big no-no. I'm going to skip down here. I was like, because your red meat intake, it may increase the risk of mortality for those already living with your liver cancer. So that's one of those things where I said consult your dietitian that is fluent in oncology nutrition, because they can tell you this meat might be bad for you. This meat, you might have all of these that are bad, but maybe this one works with you. This is all with the test that you're going to be taking, so they can figure out what's going on and what's good for you to eat and what's not. Your processed meat, avoid those at all costs. At all costs. So a lot of Americans do go out to eat. I can guarantee you 9 times out of 10, that meat is not going to be from a place where they're using grass-fed meat. It is processed meat. It comes frozen. It's a lot that goes into that. I was like, avoid it at all costs. Processed meat is a carcinogen. Actually, it is. So that is not going to help with any type of cancers, let alone your liver cancer. It is also high in iron and saturated fat. We want to avoid saturated fat. And for men, it's like the iron, the amounts of iron that you get. Women, we have a shortage of iron for the most part. Men have sometimes they have a lot of iron. So we are trying to refrain from having it make more cells and all that good stuff. So keep that in mind. What to eat during chemo. If you happen to be doing chemo, during chemotherapy treatment, it is essential for people to eat enough protein and calories, and that's often hard to do. If you've seen anybody going through chemo, it's really difficult for them to keep food down, okay? So just keep that in mind. So this means it's important for a person to try new foods and supplement their diet with the high protein and high calorie snacks, such as your chicken, your fish, your like salads, if they can stomach it, and crackers are okay. Greek yogurt and eggs. Eggs, look, you can have scrambled eggs, you know, when you eat them, you can make them mushy. I was like, they're really good, and they help keep everything down. But again, contact your oncology nutritionist so they can tell you what supplements, if you need to take some, what you're low in, and then they can supplement it. Next slide. So your colorectal cancer foods, electrolytes. I was like, not the kind, I was like, there's a lot of people that say Gatorade because the marketing has gone crazy with the Gatorade. Oh, it has electrolytes. No, Gatorade has more sugar than electrolytes, but we do need electrolytes. Like your potassium and your magnesium and your sodium and calcium are all essential minerals that keep your body, help your body and maintain the appropriate balance of fluids. Good sources of electrolytes are your leafy green vegetables like your lettuce and kale, and also spinach. Fruits like watermelon, and if you think about it, it's easy to go through. I was like, it breaks down, it's easy to go through. Bananas, avocados, I did say they were mushy. As you have potatoes, your sweet potatoes in particular, your beans, almonds, and peanuts. So again, check, and I was like, because your body may or may not do well with those. And so those are the things that you need to check with your oncology dietitian, as it says here. Nuts have a tendency to pass through, go back real quick. I was like, so nuts have a tendency, they pass through quickly. And I was just like, and so I don't know if that's something that you're going to want if you already have diabetes or have diarrhea. Proteins and your vitamins. Yes, I was just like, your vitamins are also a key part of the colorectal cancer journey. Okay, so if you have low levels of vitamin D, that has been associated with poor outcomes, and in some cases may negatively impact your survival. So vitamin D can also be found, go outside. I was like, the sun is a fantastic source of vitamin D. If you have a chance to eat outside, that's even better because you have a chance to enjoy it. So when patients are deficient, we recommend the supplements, and that's going to be, it's going to depend on what you're low in as to what we supplement with. Other important vitamins are B complex, vitamin A, and vitamin C. Those are your citrus foods, each of which play a crucial role in the body's ability to recover from and tolerate colorectal cancer treatments. Okay, so most importantly, just know you have the power, just like, to possibly avert or mitigate your chances of GI cancer. It's doable. You can do this, and food is a huge part of it. But you are required to actually do something. Okay, you can't just, if you eat not so healthy or you are obese, these are things that you can help, and you can fix that part you can do. So hoping will not increase your chances. You actually have to do something about it. Yeah. So eat well, naturally, use as many natural foods as you can. Try to stay away from the processed foods, the foods that have chemicals in them. I was like, this is going to require a lifestyle change for some. Well worth it, even if you aren't concerned about potential illnesses, even if cancer is not, it doesn't run in your family or anything like that. These are all things that you can do that will keep you healthy and keep you from getting any potential illnesses. Nutritional services are only one facet of an integrative approach to cancer treatment. Keep that in mind. We also need you to move. We need you to do, there's things that you need to be doing daily. So check out your naturopathic support. So that's going to be people that only use like foods, I was like, and all natural foods to help you out, which could include guidance on dietary supplements. They'll let you know if you need to do that, and homeopathic remedies that do not use chemicals. I find your body, if you're doing chemo, you're already getting chemicals. So the least amount of chemicals that you can put with your chemo is even better. Or if you are eating a lot of processed foods, that's chemicals that you're just not aware of. And if we can avoid that, God gave us everything that we needed to fix just about everything. So therefore, I was like, it's out there, but it's natural. He didn't make anything in a lab. So there you go. So do include movement in your day-to-day. We're going to need you to move stuff. I was like, even if it's just walking around, down to the end of the road and coming back, that's fine. Because when you don't use it, you lose it. So if you happen to do that while you're outside and getting vitamin C at the same time, even better. So to get in touch with me, if you want to get more information, I was like, I do guidance, nutrition guidance, and fitness guidance from home. It's on a Zoom. I do a lot of stuff by Zoom. And I work with a group of people, and that's what we do. We help people online. So you can catch me at restorationnutrition.com, or if you are on Instagram, I am at Restoration Nutrition, one word with an 8 in the middle. Stop living like your struggles are normal. It can be helped. Thank you. I appreciate it.
Thank you, Mocha, for that amazing presentation. If you have any questions right now, you can put them on the chat box, or you can raise your hand and ask your questions. And we'll be closing in the next 10 minutes. Any questions, any comments, any contributions from anybody, just feel free to talk right now. Thank you, Mocha. Thank you, Peace. Thank you, for Nkechi, for those amazing presentations today. I'm sure we have learned a lot about GI cancers, and we are living here more empowered to make a difference in our diet, in our habits, in our exercise levels. Please, like you heard from Mocha, add walking around in your daily agenda. And as I said earlier on, try to keep your bowels empty at least once every day. Any questions, any comments before we close? All right, so if there are no questions, one last statement from all the presenters. Peace, one last comment.
Yes, once again, thank you to all of you on the screen, especially staying with us, hanging on here with us. We really, really appreciate your time. And one thing that we do is to empower our people, our families. It's nothing else. Just know some of the tools and the activities to stay healthy. We do what we can do as individuals, as humans, and we leave the rest to God. So once again, thank you everyone and all the participants, all the presenters today. Thank you.
Thank you, Peace. Queen Nkechi, last comment.
Oh, thank you so much. Thank you all, guests today. This is something that we have some power to control, and some of them we don't have power. So the most important thing is, if you get diagnosed with cancer, yes, there's time to cry, but then the question is, where do you go from there? Try and figure out the pattern questions, because the diagnosis is so overwhelming. You could write it down while going to your physician's appointment. So when you go, you have your questions written out, ready to get answers. And please do not go on to Google treatment. Oh, I have seen my neighbor was this. Why didn't you use this? Please stay away from Google treatment, okay? Listen to your providers. Just go by their recommendations. If you're not sure, you can ask for second opinion. But please stay away from Google. Stay away from researching all herbs that could take away cancer right away. Please just follow your physician's advice. Thank you, guys.
Thank you. Allow me to do a shout out to Oga Charles Mensah for joining us today. He came in very early and he had been with us from the very beginning. Chi, Amoge, Moses, Casey, Ken, Kenneth Onyewuchi, Marcel, Delight, Osita, OFD, Ojugo, Olohitera. That should be Josephine, Onyekachi, and Tostosin and Vericia. Thank you for being with us today and for staying all through. Now, Moka, your last comments.
Last comments, eat well. If you think about it, everybody said on here that the GI cancers, they happen later in life, usually after 40 years old. That's a reason. How are you eating from the time you're young? If you are eating well, chances are you're not going to have to deal with this and like, hopefully you don't find out like in a stage 3 or 4, and maybe you can avoid it altogether. But it was like, this is your chance. If you didn't know before and you happen to be eating not so well, this is your chance. You can start today and we can move forward on making everything better and, mitigating any problems that we may already have and possibly getting rid of any problems we have. It all has to do with your food and movement. Thanks a lot.
Thank you, Moka. And also a shout out to Ezine Akinola. Thank you for patience for joining us today. And if I missed your name, please forgive me. It's not deliberate. Thank you for today. I look forward to having you again by the end of next month for our next session on staying healthy. Have a good evening. Have a good day. God bless you. Bye-bye. Also, we'll post this on our YouTube channel. Please feel free to listen to it again and share with your friends once it's posted on our YouTube channel. Have a good day. Bye-bye. Yeah. Welcome, Justin O'Kelly. How are you? I didn't know you were here. Dr. O'Kelly, thank you for joining us today.
I'm okay. You finally made it. Thank you for coming.
I'm seeing some very beautiful and wonderful people this evening. Thank you, everybody, for joining from Nigeria, from US, from everywhere, from UK. Thank you.
Yes, Marcel. Mr. Marcel, okay, Kiadeka Opugo.
Yeah.
Doc, good afternoon.
Wow. How are you? It's good seeing you here.
A long time.
Okay. I remain loyal.
Thank you. Great presentation from all of you.
Thank you for joining so early and being with us all
Anytime. I enjoyed it.
Thank you, sir.
Yeah.
I will stop recording now.
Sure,
Oh,
later.
yes.
Please, can we get the recording, please? Can we get
Yes.
the recording?
It will be. I will post on because of its weight on a YouTube channel. Please feel free
Okay,
to go
YouTube.
to it and then share.
So what's the YouTube channel? What's the name?
Center for Family Health in